Good afternoon, dear colleagues and chairs. It's a great pleasure for me to be here, and I would like to thank the organizing committee for their kind invitation. I'm going to share our institutional experience about the importance of intraoperative ultrasound guidance to achieve negative margins for palpable and non-palpable breast cancer. I do not have any conflict of interest or financial affiliation to disclose. As we all very well know that breast conserving surgery plus adjuvant radiotherapy has become the alternative treatment to mastectomy for early stage breast cancers with supporting evidence from randomized controlled trials reporting equivalent survival. Residual tumor is the most significant risk factor for recurrence after BCS, and approximately 20 to 40% of patients have positive margins, so they require a second operation and an upcoming mastectomy, unfortunately. So in most of the cases, we prefer to make re-excisions at this condition. And intraoperative sonographic guidance is being increasingly embraced by breast surgeons worldwide, as the goals of the BCS are to provide survival equivalent to mastectomy, a low rate of recurrence, and a cosmetically acceptable breast after excision. And the major advantage is to allow patients to preserve their breasts without sacrificing oncologic outcome, which requires complete surgical removal of the tumor with negative surgical margins. The real-time sonographic localization provides tumor-free margins with low excision volumes and decreases the rate of reoperations. And originally, ultrasonographic guidance has been proposed for non-palpable breast tumors. However, its beneficial effect for palpable counterparts also merit consideration according to the current literature. Since 2005, at our institution, we are routinely performing preoperative sonography to localize palpable and both non-palpable tumors. And the real-time surgeon-performed intraoperative sonography guided BCS is the preferred method of surgical choice. So the objectives of our study, the primary objective is to compare the efficacy of this method for palpable and non-palpable breast cancer with respect to margin status, re-excision rate, tumor-free tissue sacrifice, and cost-time analysis. And as secondary objective, we analyze the relationship between intraoperative assessment of gross macroscopic and sonographic margins and frozen section analysis with histopathologic results. This study was observational and non-randomized with prospective acquisition of data from a clinical database compiled at our clinic, and the clinical pathologic data, successful lesion removal, and analysis of the results as regards margins were evaluated, and requirement for synchronous and metachronous re-excision was evaluated for both tumor types. All the statistical analysis was carried out using SPSS, and categorical variables were compared by Pearson's score test, and continuous variables were assessed using t-tests. A total of 259 patients with the diagnosis of in situ or invasive carcinoma had our technique between the 4 years period. The method includes intraoperative guided tumor localization and breast conserving surgery, sonographic and microscopic assessment of the surgical margins by the surgeon, frozen section analysis of the 6 margins from each specimen, cavity-shaped margins from tumor bed for permanent section analysis. Here we go. We routinely perform preoperative sonographic evaluation for every patient at our institution. And intraoperatively, after we prep and rape the patient, we make sonographic visualization of the lesion. At the same time, before making our incision, we determine the tumor margin under real-time sonographic guidance, and we always perform the real-time guidance all through the operational period. And then after the excision, we perform sonography again to confirm that the lesion has been excised, and then we also perform the sonographic evaluation for the tumor bed that there is no tumor at that stage. So if you look at the patients and the tumor characteristics, the age was there were most of the nearly half of the patients tumors were palpable, and 55% was non-palpable. There was no statistically significant difference in terms of age, menopausal status, and body mass index. There was a difference, of course, as expected by means of tumor size, the palpable tumors were larger in diameter than the non-palpable tumors, and the grade was statistically significantly lower in the non-palpable group. So if you look at the techniques results of the accuracy, for both types of the tumors, it was possible to excise the lesion with 100% of accuracy. Sonographically negative margins verified by the frozen section was 91 versus 92% for palpable and non-palpable tumors. Identification of involved margins via specimen sonography was 90 to 100%, and the overall positive margin rate determined by the frozen section analysis was 2.8 for palpable and 1.9 for non-palpable tumors, and the reoperative requirement was found to be 2.3 overall. So the overall positive margin rate determined by the frozen section analysis was 2.3%, and 86% of the patients with a diagnosis of positive margin by the frozen section analysis proved to have significant degrees of pure or mixed DCIS at the findings of pathologic evaluation. A second operation was required only in 6 cases. Half of them was palpable and the rest was non-palpable, for either determination of closed margins or multifocality at cavity-shaped margins, but the operative specimen pathologic analysis revealed nothing significant, and also the calculated resection ratio and cost time analysis was found to be similar between the groups. So in BCS, ultrasound satisfies requirements for diagnosis and treatment of breast cancer and has been extensively used in the fields of preoperative evaluation, procedure-guided diagnostics, intraoperative tumor localization, and margin assessment. So accordingly, as a study objective, we focused on breast cancer patients with BCS who underwent ultrasonography for intraoperative tumor localization. If you review the literature, we see that the case series is more than 50 cases. The intraoperative sonographic guidance resulted in very low re-excision rates varying between 4 to 19%, and the local recurrences has been reported to be near lineal. The results of the presented study show that intraoperative continuous use of sonography provides significant surgical accuracy for either palpable and non-palpable breast cancer, and the proportion of adequate clear resection margins was high, more than 90%. Accordingly, the improved margin clearance achieved by means of this technique lowered the need for either re-excision or an upcoming mastectomy maybe. Moreover, cavity shavings from tumor beds for permanent sectional analysis decreased the need less to 2.3%, and avoidance of further treatment has a potential to reduce the adverse effects, cosmesis, and psychological distress on our patients. So, ultrasound-guided surgery results in significantly smaller specimen volumes as reported in literature, and also this could lead to improved cosmetic outcomes, thereby increasing patient satisfaction and quality of life. The considerable improvements in surgical accuracy provided by ultrasound-guided BCAs might only be questioned by the fact that the proportion of the tumor-free margins was less in case of additional DCIS, and in our study it was 15 out of 22 patients. So ultrasound-guided BCAs can substantially improve a surgeon's performance, and one of the most crucial issues is that surgeon should gain competence in this technique to design preoperative planning, to avoid need for a radiologist at the operating theater, to perform continuous intraoperative scanning, and to enhance hand-eye coordination. And required expertise to perform this technique has been recommended up to 8 procedures or 10 procedures by our opinion. Another important issue is the cavity-shaved margins. In literature, cavity shaving has been reported to have the rates of positive margins and re-excision among patients in partial mastectomies. According to the design of our routine clinical practice, we perform cavity shaving to all cases. So this approach decreased the need for operations in only 10% in our series, and this discordance might be attributed to the beneficial effect of intraoperative sonographic guidance that enables to real-time visualize and evaluate the margins at the time of the surgery, so thus cavity margin is more tumor-free than expected in the literature. To conclude, we demonstrated that ultrasound-guided breast conserving surgery for either palpable and non-palpable breast carcinomas facilitates negative margins without much need to secondary interventions, with less healthy tissue sacrifice, with satisfactory cosmetic results, and with lower costs. Ultrasound-guided BCH is an invaluable and effective modality for both palpable and non-palpable breast cancer in obtaining clear surgical margins with optimum resection volumes and reducing reoperations. Sonographic and frozen section assessment of the specimen margins, together with shaving cavity margins of the tumor bed for permanent analysis, could be a method for minimizing the requirement of reoperations and mastectomies, I believe. I thank all of you for your attendance and patience. Thank you very much.